Greetings from Tata Medical Center. I am Dr. Sanjit Agrawal. I would like to thank Dr. Safiq and organizing team for inviting me for this region. So what I'm presenting today is current paradigms in axillary management of breast cancer. So if we talk about axillary management, we see axillary management now, not only axillary lymph node dissection, is mainly sentinel lymph node biopsy, multiple pressing question that do we need to do axillary lymph node dissection in all sentinel positive patient? How we will deal in post-NSCT sentinel node positive patient converted to node negative? Axillary RT as a substitute to ALND, and no axillary staging in certain group of the patient where you can even think for avoiding sentinel lymph node biopsy. So why we are thinking of de-escalation? Because we know the disadvantage of axillary dissection. It starts from the early complications, seroma and shoulder dysfunction, and the late complication. We all know that multiple, like loss of sensation in the mid part of the arm to the lymphedema. So this study I want to quote. So this was first published by the Fisher et al. in in 1985 and then 2002. And this study has given us the concept of the axillary de-escalation because this study has three arms. In one arm, the total mastectomy was done only. In the one arm, radical mastectomy means mastectomy with axillary clearance. And in the one arm, mastectomy plus radiotherapy. And it was found that even if you are not doing axillary treatment in total mastectomy only group, it has no impact on the survival. And this was the era of non-screened area where the mainly patient in this group were having advanced breast cancer and not having a proper adjuvant treatment what we are providing now. So at that time for the chemotherapy, probably only 5-fluorouracil was available, and for the endocrine treatment, only tamoxifen was available at the time of the enrollment in 1980s, and even no trastuzumab was available. Since that era, axillary treatment has not given any survival advantage, and we really need to think of doing axillary clearance in any patient in our clinical practice if it is not giving any survival benefit. What it said that ALND provide prognostic information and the systemic therapy decision making. And slowly it has changed. We know that we base our systemic therapy decision based mainly on the IHC status or the biology of the tumor. So we really need to think again that why we are doing ALND if it is can be safely avoided. So how to avoid it? So we all know the sentinel lymph node biopsy is a major procedure in this group where you can stage the axilla and see the nodal status of the patient and can define the adjuvant treatment. So three people have mainly done the studies. It's a Veronesi et al., Cragg et al., and Mansell and Goel et al. So in first two study, what was found that SLNB had same overall and disease-free survival compared to axillary lymph node dissection. And in Almanac trial by Mansell and Goel et al., it was found that the SLNB improved quality of life and the lymphedema rate. So these three studies have established sentinel lymph node biopsy in clinically node negative patient, mainly in upfront surgery. And after these publication from around 2005, the staging procedure of the choice is sentinel lymph node biopsy, not ALND in clinically node negative patient. When we have seen the survey in our Indian practice, and we found that the still sentinel lymph node biopsy is not a routine practice, especially in the district town center and non-tertiary care center. And when we ask about the reason for this is that majority of the surgeon have quoted that they are not doing sentinel lymph node biopsy because radioactive dye is not available to dye. So this is you can use methylene blue dye only, but we all know that methylene blue dye, the identification rate is less than 90%. False negative rate is more than 10 to 12% as per the quoted literature. And generally after removing of the blue node, you can't map the axilla just like we do with the gamma camera in the radioactive dye method, that if there is any residual hot node. To use is ICG, so fluorescent dye for doing sentinel lymph node biopsy. And we all know the radioisotope dye has some limitation. And even the guideline also say that we can use the alternative dye for the radioactive dye. So it's easily available, the ICG dye. And even in the abroad also, there is a problem of availability of the radioactive dye. And it has gained a lot of momentum to use the alternative dye, which can replace radioactive dye for sentinel lymph node biopsy. So how we do ICG guided sentinel lymph node biopsy? So inject ICG dye plus blue dye. We do the gentle massage after 2 minutes and then use the ICG camera to see the fluorescent channel and the fluorescent node. So this is, you can see we injected a ICG dye here. You can see the channels here going towards the axilla. So you can guide your incision based on the marking of the fluorescent channel. And we decided to open the axilla here. And this is the blue node and fluorescent node. And after removal of the fluorescent node, you can map the axilla for any residual fluorescence and remove any node which is fluorescent, and it's completing the axillary mapping just like we do for the radioactive dye use. So the major problem with the fluorescent dye that if it is spill in the surgical field, the whole of the area will be fluorescent. So what we suggest that use tegaderm dressing in the dressing site where you are injecting to avoid spillage in the local area. Meticulous dissection of the lymphatics and clipping of the lymphatics to avoid spillage in the axillary area, and always top up it with the methylene blue dye, because if there is a significant spillage and fluorescence in the axilla, the whole of the axilla will look fluorescent. To summarize, this is the institutional data we have published. So these are the two studies we have published comparing technetium dyes. The first study was published in JGO Global Journal. And what we found that the diagnostic performance of the both the method, the methylene blue and technetium compared to the ICG plus MB is almost equal. So we had identification rate of almost 97% with the ICG plus MB and 95% with the technetium plus MB. We compared in the next study in around 1,500 patients by different methods, sentinel lymph node biopsy using MB alone or methylene blue dye alone, or radioactive dye alone, or methylene blue plus radioactive dye, or methylene blue plus ICG. And the maximum identification rate you can see is in the methylene blue plus ICG, that's 98%. But the little bit drawback, because IC is very sensitive. So we have removed around 3.4 median number of lymph node, sorry, mean number of lymph node with the standard deviation of 1.8 in the ICG group. So it's ultra sensitive. So you need to inject it adequate amount and try to do surgery as early as possible after the injection to avoid the more uptake in the lymph node. So this is the little bit drawback. So to summarize, sentinel with the blue plus ICG, what you need to do, inject 1 ml of methylene blue followed by 5-minute gentle massage, followed by 1 ml of ICG with the 2-minute of gentle massage. Axillary incision you can guide by using ICG mapping, and in 90% of the patient you can see the lymphatic channel going from the breast towards the axilla. Avoid spillage by three small tricks. Pressure dressing after injection. So we use tegaderm, meticulous dissection, and clipping of the lymphatics. Axillary mapping can be done after sentinel lymph node removal by seeing the residual fluorescence. Identification rate as per our data is around 99% now in the last 3 years. What you need to see, because ICG is excreted by the bile, so you need to see the liver function. If it is grossly disarranged, use alternative method. And the skin necrosis and hypersensitivity reaction is rare with the blue plus ICG dye in our as per our 1,500 patient experience, what we have published. So coming to the next, so first question is covered, SLND can be done. If you don't have radioactive dye, you can think for using blue plus ICG, or even the fluorescent dye, fluorescein dye with the blue torch, which is very popular now, recently published by the EMS New Delhi. So the traditionally what we had followed, that if sentinel is positive, do axillary lymph node dissection. But what in retrospective data we have seen 20 years before, that sentinel is only positive node in 70% of the patient. And the question we have thought at that time as a world breast surgeon or the surgical oncologist, can we avoid LND in selected group? Because we are seeing that only sentinel is the positive node in 70% of the patient. So to address this question, we have four major RCT, which I want to quote. The RCT is based mainly on the size of the sentinel lymph node metastasis. So micromets is between the size of the metastasis in the sentinel lymph node is 0.2 to 2 mm, and the macromets is the greater than 2 mm. So 4 study, G11 study, IBCSG study, AMROS study, and Cenomec study. What the inclusion criteria, carefully read the inclusion criteria. Z11 included mainly breast conservation surgery and up to 2 sentinel lymph node when the tumor size was less than 5 centimeter. IBCSG included both BCS and mastectomy, but they included only micromets, means SLN metastasis size is less than 2 mm. AMROS is both BCS and mastectomy, any sentinel positive. And recently we have seen the publication of the Cenomec trial, where they have included only macromets and tumor size was between T1 to T3. G11 was mainly the ALND. The randomization was between ALND and no axillary treatment, means stop at the sentinel. And the 10-year outcome was the equal disease-free survival. But we need to take these trial with the pinch of the salt, because these trial have major limitation. The IBCSG study micromets only, and it was found that disease-free survival was equal. Similarly, AMROS, there are two groups. One is ALND, and instead of observation, it was axillary RT, and it was found that in 10 years, no difference in axillary recurrence with the better quality of life. But what we need to think for the data, that contralateral breast cancer was more in the radiotherapy arm, and it was significant. So we need to think as a caution to offer radiotherapy as an alternative to ALND. The Cenomec study, what changed is recently published, so it included only macromets. They said that the one group is observation, means stop at the sentinel level, and second is the ALND. Their result is 5-year equivalent recurrence-free survival. But what you need to think is that in this study, 90% in sentinel group only have received regional nodal irradiation. So compare, they said that it's observation and ALND, but it's mainly comparing ALND to the RT as AMAROS trial. Good thing in that they have included T3 patient, and they have included macromets only, and they have included a fair number of mastectomy patients. So with the Cenomec study, we can say that axillary RT may be an alternative even in the mastectomy patient, in T3 patient, but it's for not for SLN only, it's SLN followed by regional nodal irradiation in 90% of the patient. Can we adopt this technique in our practice? So I want to quote the data, what we have published. So these are 282 patient data. And what we have done, we have compared the axillary metastasis, means how many patient has metastasis, compared to the ALND arm, the G11, IBSG, and AMROS. And you can see that our sentinel non-sentinel positivity is way higher compared to the ALND arm of the G11, IBCSG, and AMROS study. And we need to think before adopting these, because our non-sentinel metastasis is bit higher compared to the ALND arm nodal metastasis. So we have divided this group of the patient. We have done ALND in this group of the patient, and we tried to see the survival difference between the two groups, where the patient had both non-sentinel negative. So we included all patients who were fulfilling the criteria of G11 criteria, and we were not offering observation only. And we divided the patient in one group where further metastasis was found, and in one group where further metastasis was not found. What we have seen that there is no difference in survival between the two groups based on the non-sentinel positivity arm. Is the information making any decision therapy change? So what we have done, we have taken information of sentinel only in G11 group, G11 eligible group in our group, and taken information of sentinel plus ALND. And what we found that the additional nodal positivity information is changing decision making for chemotherapy and radiotherapy in only 3% of the patient. So if you do additional ALND, even in our setup, being a large group of the patient having more non-sentinel positivity, probably it will not make any decision-making change as per our data. So what we suggest that in ITC and micromets, we can avoid safely axillary clearance. For the macromets, T1, T2, and BCS up to 2 sentinel lymph node, no LND is still a question mark because we have very high nodal positivity in this group, non-sentinel positivity, and we really need to wait for the post-NOC result. Macromets with up to 3 positive node, mastectomy or BCS, axillary RT is in a consideration, but we need to set up the axillary RT protocol, and we need to be careful of the AMROS data, contralateral breast cancer, significant increase. Recent Sinomec trial is very convincing, but it's only 5-year data, and we need to wait for 10-year data. So still, I will say for the ITC and micromets, no axillary clearance, but for the macromets, we need to think for the no LND in a very selected group of the patient, and axillary RT, we need to wait for the Sinomec 10-year data for see the contralateral breast cancer event. No axillary staging in a very selected group of the patient. Recently, SOUND trial has been published. Is a CT10 ER positive HER2 negative patient. What they have done in one group of the patient, sentinel was done, and one group of the patient only observation, no axillary staging. Consider this as a CN0 in clinical and radiological examination as CN0, and it was found that there is no difference in disease-free survival. There are other ongoing trial, INSEMA trial, and 3 more trial. And we need to wait the result because SOUND trial data is also 5-year data. So we need to wait for the final result, 10-year result before adopting this in clinical practice. It's not very applicable to us because we see mainly non-screen patient, and our group of the patient having a CT1 ER positive and HER2 negative is a very small chunk of the patient. But this is the data we should look upon, the maturity of the data, and trying to avoid the axillary clearance, even axillary staging in this group of the patient. Coming to sentinel lymph node biopsy post chemotherapy. So in this group, we have 2 groups, CN0 to start with. Can we do sentinel lymph node biopsy in this patient? And CN positive, biopsy proven not positive, converted to N0. Can we do sentinel lymph node biopsy in this group? So first group, SLNB post chemo, CN0 before chemotherapy. We have enough evidence that we can do sentinel lymph node biopsy in this group with the Guinea 1 and Guinea 2. These are 2 French multicentric trial. First group was the validation ALND after sentinel, and it was found that the false negative rate was only 8%. And second is the MD Anderson study, a large study with the identification rate of 97% and the false negative rate of 6%. The Guinea 2 study is a outcome data in CN0, and what it was found that the number of patients having a node negative disease is 419 patients out of 589, and only 1 axillary recurrence where only sentinel was done post chemotherapy. But mind you, these are CN0 to start with, and sentinel was done after chemotherapy. So what's the positivity rate? So if you have done sentinel lymph node biopsy in this group, CN0 to start with, what it was found that positivity rate, sentinel positivity rate in this group post chemotherapy is very less, is 2.16% only. As per the Tata Medical Center data, we found that the sentinel lymph node positivity in this group is 3.4%. An interesting observation in this group is that if they are achieving breast PCR, the sentinel was negative in all. So if you are achieving breast PCR in a CN0 patient who is having chemotherapy, chances of having sentinel positivity is almost 0%. And these two trial results we need to look upon, UBreast-01 and Aslan trial. What they are doing, they are giving chemotherapy in CN0 patient, and post-chemotherapy, they are doing sentinel lymph node biopsy only if they are not achieving breast PCR. If the patient is achieving breast PCR, sentinel omission is being done in these two trials. And if these trial will come as a positive result, then probably we will avoid sentinel in this group also, even sentinel in this group, just like we are thinking as sound and INSEMA trial. Coming to the last possibility in sentinel lymph node biopsy. So if the patient is starting with node positive, T1, T2, N1, and N2, you have given chemotherapy in this group of the patient. Patient has converted to clinically and radiologically CN0 because 50% of the patient will have axillary PCR in this group. Can we do sentinel lymph node biopsy and avoid axillary clearance in this question in this group? So we have 3 study, and all the study what they have done sentinel lymph node biopsy in this group of the patient. So N1 converted to N0. They have done sentinel lymph node biopsy followed by axillary lymph node dissection, and the goal was to achieve false negative rate of less than 10%. So in these all 3 study, I have summarized all the data, and what it was found that FNR was more than 10% in all these 3 study, irrespective of the patient allocation. And the subgroup analysis, what we found in these 3 studies, that FNR was less than 10% when dual dye was used, or 3 or more lymph node was removed, or clip node was removed. So what is clip node? You clip the positive node before chemotherapy and remove it after chemotherapy with sentinel lymph node biopsy. So to summarize all these 3 studies, overall false negative rate was more than 10%, and FNR was less than 10%, mainly when dual dye was used, 3 or more sentinel lymph node removed, or clip node removal. So what is targeted axillary dissection? This is a term where you are clipping the node before chemotherapy and you are removing both sentinel lymph node plus clip node post chemotherapy. This was MD Anderson study. They have used the same technique, clipping the node before chemotherapy and trying to remove both clip node and sentinel lymph node. And what they found that the false negative rate is around 4.2%. And clip node was not among the sentinel lymph node in 23% of the cases. In this study, they summarize that if you are doing sentinel lymph node alone, the false negative rate is 10.1%. If you are using only clip node, not even doing sentinel, only removing clip node, the false negative rate is 4.2%. But if you are removing both sentinel and clip node, the false negative rate is 1.4%. So TAD has reduced the FNR significantly from 10% or more than 10% to 1.4%. But the problem is, you can see here, this is the clip here. You need to use some of the advanced methods to localize that clip because it's very difficult to place wire in the clip node, and they have used radioactive seed. So these techniques are not, unfortunately, not available in India at present. This is TMH Mumbai study. You all know they do low axillary sampling, and they tried low axillary sampling in this specific group of the patient, post-necessity sentinel node positive converted to N0, and they found that the false negative rate was 9.9%, and compared to the sentinel, it was 19.7%. But the major problem with this study is that median sentinel, which was removed in low axillary sampling, is 7 lymph node. And we don't need to know the outcome data of removing more than four lymph node and the lymphedema. But overall, low axillary sampling has worked in the post-anesthetic setting with the FNR of less than 10%. To summarize, the FNR was less than 10% when dual dye was used. You can use blue plus ICG greater than 2 sentinel lymph node, not possible in around more than 50% of the patient as per the Indian data. Western data quote around 90%. Axillary sampling plus sentinel is 9.1% as per the TMH data. But we know that the median number of sentinel lymph node removed in this study was around 7 node. You can use targeted axillary dissection, but problem is how you will localize that clip node. You need radioactive seed, radar, or max seed. Unfortunately, it's not available in India. You can use wire, but wire is very cumbersome with a high failure rate for the localization of the axillary clip node. So at present, targeted axillary dissection, we need max seed, radioactive seed, or GPS clip technology to target that node. So till now, we have answer of using axillary sampling in India. And what we propose as a group that what you can do is that you can do either low axillary sampling, but at present we are doing a study where we are clipping axillary lymph node and we are doing a specimen mammo and CR using and seeing that clip node is present or not. Because if the clip node is present within that sentinel lymph node, you are more unsure that you have removed the clip node. And as per our data, it's around 86%. And as per quoted literature is 75 to 93% of the time, you will see that clip node is within the sentinel lymph node. So you can clip the node and you can do sentinel lymph node biopsy only because we don't have the facility to target the clip node. And you will be successful in identifying clip node in 9 out of the 10 patients. If there is no clip in the sentinel lymph node, if you have removed more than 3 sentinel lymph node, that's the 5% of the population, you can be assured as per the data that your false negative rate will be less than 10%. But if there's no clip in the sentinel lymph node, and if you have removed 1 or 2 sentinel lymph node, this is only 5% of the population where you need to do the axillary lymph node biopsy. So clipping axillary lymph node, even if we have no facility of targeting it by radioactive seed or max seed, but if you can use the CR my specimen mammo and removing more than 3 lymph node, you can avoid axillary clearance by doing a plain sentinel lymph node using this technique, using specimen mammography and CR. Can we adopt the same G11 and IBCSG in the post-necessity patient? So answer is no. We don't have any evidence of avoiding ALND in SLN positive patient post-necessity. Do we have any evidence of using RT as an alternative to the ALND at present in post-necessity setting? We don't have any evidence, and we need to wait for the ongoing alliance trial for this particular group, where we can do the ALND axillary RT instead of the ALND in the post-anesthetic setting. To summarize, I will say that Professor Fisher or Sir Fisher has established that ALND is only a staging procedure in way back in 2002 with the final 25-year publication. Professor Varanasi or Sir Varanasi has changed the concept of the using sentinel lymph node biopsy as an alternative method, and now we can use it in the pre and post chemo both. In SLNB positive, the question mark of doing axillary clearance was given by the Professor Gugliano, and in selected group of the patient, we can think for observation or axillary RT, means not doing ALND, either observing or axillary RT. Still, the data has some question mark, and we need to wait for the POSNOC trial result led by the Professor Goel in UK and see the final result of the POSNOC and be confident in de-escalating axillary surgery in this group of the patient. In node positive, Professor Bogatti from the USA has done a major role, and we can think for the sentinel with the more than 2 lymph node removal or targeted axillary dissection or axillary sampling as per the TMH data. No axillary staging in a very early patient, T1 N0 patient, upfront surgery, and in post-anesthetic patient, we need to wait for the final result of the multiple trial, which is ongoing for going no axillary surgery, even avoiding sentinel, both in upfront surgery and the post-chemo group. So with this, I will say thank you, and I am happy to answer any question.